Okay, class, we looked at our charting tips, and now I want to go over this 24-hour clock and charting activity that I posted for you. There are many, many different ways to chart things. We already discussed that. I said I could give these to 10 different nurses, experienced nurses, and everybody's going to document it just a little bit different, and that's okay. We're just trying to learn, how do we try to condense things down? How do we make things a little bit more streamlined and simplistic without having to chart a book? So this first one I gave you, it says your resident had vital signs at 9 a.m. His vital signs are temperature 98.6, pulse 86, respiration 16, blood pressure 120/64. How would you chart this? Now, one thing to keep in mind is you don't have to put the temperature 98.6, pulse 86. I could put just vital signs 98.6-86-16-120/64. If you do it in TPR blood pressure order, I can do that just putting vital signs and listing my values. If I'm going to do them out of order, I really should specify temperature this, pulse this, respirations this. The other thing is, when we talked about vital signs, is we should always get pain values. Okay, pain levels should always be done when we're doing vital signs. So I should have a pain value here as well. And then if I was working in an area where my patient was on oxygen or on a cardiac floor, they would probably have me get an oxygen saturation. Even though that's not considered a routine vital sign, that is something we generally tend to get when we have patients on a cardiac floor or having respiratory issues. So the way I documented this, I put 0900 for my 9 o'clock. Again, no semicolons, no AM, PMs. VS, so vital signs, 98.6-86-16-120/64 for my blood pressure, denies pain. And then I drew a line through the excess line here, first initial, last name, and title. And remember, if we are a student CNA, it would be SNA. And that's fine. I really don't need to document anything else with this. Okay. The next one, it says at 10 a.m. when you were turning Mrs. Smith, you noticed a reddened area on her buttocks. You told charge nurse Mary K. RN, what would you chart? So again, different ways to do this, but I put 10 a.m., so 1000, reddened area on buttocks, repositioned. So, and I could put reddened area on buttocks noticed. I could have put it reddened area on buttocks noticed when being repositioned. That way they would know I had been repositioning her and this still happened. So that might actually be a good way to put this as well. There are different ways to do this. This is just one approach that I had here. So reddened area on buttocks, and then I put comma repositioned, or as I said, we could put reddened area on buttocks noted when repositioning. MKRN notified, and then first initial, last name, and title. This next one here, and as far as this, if let's say Mary Kay has me put topical ointment on it, let's say she says, okay, go ahead and put some A&D ointment or some Balmex on it. If I did that, then I could put my next entry, say 10:30, Balmex applied to buttocks area as requested by MKRN. Okay, if I'm the one doing it, because remember, we are allowed to do topical over-the-counter ointments. But if Mary Kay puts something on it, then she would have to document it herself. The next entry, it says your resident went out to lunch with the family from noon to 2 p.m. She told you she had a wonderful time. What would you chart? Now, again, different ways to do this. So my first thought was to do a 12 o'clock entry, left facility with family. Now you notice, again, I'm not putting patient left facility with family. If it's in the patient's chart, it's about the patient. I didn't put Mrs. Smith left the facility. Again, if it's in her chart, we're assuming that you're talking about her. So left facility with family. Okay. Draw a line through it, first initial, last name, and title. At 2 o'clock, I put returned. And I could put return to facility, but if I put return, I would kind of assume that people would understand what I was talking about there. So returned states She had a wonderful time. Now, because I'm actually putting what she states, I would need to put that in quotations. Now, do I need to put that? Do I need to put that she states she had a wonderful time? Maybe not. I mean, it might be enough just to put that she returned to the facility, though I would probably want to make some type of notation that she was feeling okay or that she was doing okay. Now, had she had issues with depression or anything like that, state she had a wonderful time might be a really nice entry to put in there. The fourth one, it says at 4 p.m. your patient starts complaining, C/O's complains up. So at 4 p.m. your patient starts complaining of chest pain. You tell the charge nurse, Sue RN, what would you chart? So I put 1600, C/O complains of chest pain, pain scale 8 out of 10, Sue RN notified, first initial, last name, and title. Now, could I go into more detail? I could, absolutely. I could ask not only the pain scale, I could ask if the pain travels, if it, which is radiating pain, if they're sick to their stomach, if I notice any cold, clammy skin. I could get vital signs, but Sudo's probably going to tell me go get vital signs and an oxygen saturation while she's coming in, or she may want to get them herself. So again, there are different ways to do this, but that's fairly complete and brief and concise. Just the complaints of chest pain, pain scale 8 out of 10. It's 11. Now, again, let me just go back to this pain thing again here. So we did talk briefly about pain. I told you as a CNA, I always wanted you to know where the pain was and what the pain value of it was, the pain scale level of it. But there are other things that nurse should be assessing for, and things that you can assess for as well, though really as a CNA, as long as you know where the pain is and the pain level, I think you're fine. But knowing, are there things that make it worse? Are there things that make it better? Is it a stabbing pain? Is it a crushing pain? I mean, how would they describe it? Those are all things that we would probably want to know, but they really would be more the responsibility of the LVN or the RN caring for that person. The fifth one, it's 11 p.m. and your resident has trouble breathing. You notice his respirations are rapid and you hear audible wheezing from him. Now, I think originally when I put these little entries in, I was just looking at them as individual charting episodes, not the same patient. So obviously I was talking about Mrs. Smith earlier. Now I'm talking about a man. But 2300 would be my 11 p.m. Complains of trouble breathing. Respirations 28 with audible wheezing. MKRN notified. Now, there are always other things I could have charted or done. I could put that I put his head of his bed up, because when someone's having trouble breathing, putting the person in a Fowler's or high Fowler's position is sometimes very helpful. I could have checked an oxygen saturation level. That would have been nice. But for what I gave you for this little vignette, just the complaints of trouble breathing, respirations 28, audible wheezing noted or with audible wheezing, MKRN notified, and then my first initial, last name, and I put RN this time, but if I was a CNA student, it would be an SNA. And then number 6, it's 12:15 a.m. and Mr. Smith is asking for a sleeping pill. You tell Sue RN, what should you chart? So again, 2400 is the end of our chart. So after midnight, it's now going to become 0001 and on. So this would be 0015, unable to sleep, asking for sleeping pill, Sue RN notified, first initial, last name, and title. Now, can I go back later and chart that I find them sleeping? I could do that. But if Sue does take them a sleeping pill, it's actually their responsibility to document the results of that sleeping pill. But other things I could have done for this person, if they're having difficulty sleeping, I could have seen if they need to go to the bathroom, if their sheets are wrinkle free, if they would like a back massage. I could have tried some comfort measures, repositioning them with pillows. I could have done all of that for them too. But for what I gave you in this particular scenario, just what I charted there would be fine. So again, many different ways to do this. I'm just giving you a sample of one way it can be done, but being as brief and concise, but telling everything that you need to is a really important skill to learn in nursing. Now, I also put a few questions on here. So number 7, it says you make a mistake on an entry. You should correct it by, and you would draw a line through it. You don't white it out. You don't take black um, a black Sharpie and like completely color it out so nobody can read it. It's just draw one simple line through it. You mark error over it and you initial the entry. Number 8, when you're charting, it's okay to skip lines in case you need to go back and add something later. No. So let me go back here to these. Had this been one person I was charting on, I would chart each entry 12 o'clock, 2 o'clock, the 4 o'clock entry would be here, the 2300 entry here. Each line, I wouldn't leave any of these blank lines here. So this right here, if this had been the same patient I was charting, I would put the next entry right there. The next entry goes here. The next entry goes here. You don't leave blank lines. Number 9, is it okay to chart for someone else? No, you chart what you've performed, what you've observed, the work that you have done. It is their responsibility to chart. If someone else has come and done something, it's their responsibility to chart that. Number 10, charting should be done in, and out of my choices there, it would be black ink or the facilities policy. So I will tell you, my very first job that I got as a nurse, our policy, and this was long before computerized charting came into play, but our policy at the facility where I worked at is day shift 7 to 3. This was before 12-hour shifts really came commonplace. But the 7 to 3 shift charted in blue, the afternoon shift from 3 to 11 charted in black, and then the night shift charted in red. So you always knew what shift is. So if somebody forgot to put AM or PM, there wasn't any mistake. Well, you know what? Military timing has become the standard for all healthcare practices now. There's just so much less confusion going on as to when something happened. And because of military charting, doing it in different colors really isn't that beneficial. Also, if they have to copy the chart for something, they found that some colors don't copy as well. So most places will just have you chart in black. Some will be blue or black. Either one will be fine. So you really do need to know what your facilities policy is. Number 11, all entries should be dated. And that is true. But let me go back here and explain what I mean by that. So you notice here on this charting one here, I put 0900. I didn't put the date in 0900. Normally what they do on the old style charting like this is they would date it with today's date. So they would actually stamp today's date right here, and then you would make all of your entries under that day, and now here after midnight the new date stamp would come on for the next one. So they are technically dated and then timed. So yes, that is a true question here. All entries should be dated. Yes, they should. When charting, is it okay to use abbreviated words? And that is a yes, so long as they are approved abbreviations for your institution. So again, you cannot be making up your own abbreviations. All of the texting abbreviations that you're used to using doesn't work for nursing. Nursing has its own abbreviations. So for instance, with, it is not a W with a slash, it's a C with a line over it. And without is S with a line over it. So you need to make sure you're using medically approved abbreviations, and they have to be approved for your institution. So every facility I've ever worked at has had a policy on what approved abbreviations are. 13, charting should always be neat and legible, and that is true. And again, it's the main reason why electronic charting came into place is because there was so many mistakes happening. Again, the biggest purpose of your charting is to make sure that patient care is being done correctly and passed on correctly to the next person, so we can always have a tracking method to make sure proper care is being done. And it does also help you with legalities of nursing as well. But what was happening is doctors would come write an order and you couldn't read it correctly, and so sometimes improper care was being done. So it's one of the reasons why medical charting has gone over to the electronic format. But as I mentioned before, I have worked at the hospital where times where the computer system is going through updates, or it's something's wrong with it and it's down. We bring out good old pen and paper again and do long style charting. So it is something you kind of need to learn the basics of. And charting, even if you do it electronically versus if you do it old school, you still need to get in that habit of what's important, what do I need to pass on to that next shift, what is critical that it be, that the information is being sent down the line versus what can I get rid of, because you really do want to learn how to be as efficient in your job as you can. And then the next question says charting is for you and your coworkers only, and that is false. Again, it is primarily for the healthcare team. That is true. Everybody on the healthcare team tends to document it. And remember what we talked about back in the first couple weeks of school. You should never be in a person's chart that you don't need to be in. If you're not taking care of that person, you have no reason to be in that chart. So it's not like anybody who wants to get into a chart, just because you work at a healthcare facility, it doesn't give you the right to be in a person's chart if you're not taking care of them. But it is also a legal document, and the patient has a right to it. So keep that in mind, and that patient can share it with their family, with their attorneys, with whoever they choose to as well. So we will stop there, and hopefully that will give you an idea of some basics of charting. This is something that you'll get a chance to practice with when we get into the clinical setting.